Welcome, everyone. I'm Christine Basilar, Director of Business Development for the Western Region at Rogers Behavioral Health, and I'm your moderator for today's webinar. So joining me today are two members of our medical staff who understand the unique needs of people with ASD and co-occurring mental health conditions. We have Dr. Marty Franklin, Clinical Director of Rogers Philadelphia location, and Dr. Joshua Nadeau, Clinic Director of Rogers Tampa location. So before we get started, I wanted to give a quick overview of the format. The webinar today is scheduled for 90 minutes and there's no need to check in. To receive CE credits, you must be logged into the webinar for the entire program. A PDF of the PowerPoint slides and list of references will be available after the program via an email from ce-go.com. In addition, a recording of the webinar will be published on the resources section of our website within the next few days, so you can rewatch. Our speakers will give a 75-minute presentation, and following their presentation, I will facilitate the Q&A session. If you'd like to ask a question to our speakers, please do so during the presentation using the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you just simply click on the Q&A button on the Zoom taskbar, and I'll review the questions submitted. Then the presenters will address them during the Q&A portion of the webinar. So now I'll turn it over to our presenters.
I guess I'll jump in here. So I'm Dr. Josh Nadeau, and thank you very much, Christine. I appreciate it. Dr. Franklin and myself have each declared that we don't, nor do our family have any financial relationship within the last 12 months with the products or services we're going to be discussing. You'll find there won't be many products that we'll be discussing. We also, in terms of the people who were involved in planning, they also do not have any financial relationship. In terms of the learning objectives for this presentation, upon completing this webinar, you should be able to describe at least 3 important reasons for including effective education in the treatment of anxious and depressed individuals with ASD. You should also be able to list 3 advantages to using the SUDS among anxious and depressed individuals with ASD. And you should be able to summarize the 7 critical components of an effective safety plan for anxious and depressed individuals with ASD. In terms of what we're going to cover during today's webinar, Dr. Franklin's going to start us off by talking about affective education, more or less what it is, an overview of it. When we talk about things like alexithymia and ASD, what we're referring to. And he's also going to cover different techniques that we use to build skills with emotional identification in anxious and depressed individuals with ASD. I'll be discussing mood monitoring, specifically how to use the SUDS to give an objective rating of a subjective experience. We're going to talk about the transitory nature of mood and some of the challenges and opportunities that provides for us. We'll talk about the difficulty with using momentary ratings in a summative way by asking questions like, how was your day? And then we'll turn to safety planning. We'll revisit the SUDS that we've introduced and talk about how to use that as a decision-making tool. We'll talk about when a safety plan is necessary and the advantages that it provides. And we'll also cover some of the critical elements of the effective safety plan, and I'll go over an example of that plan. And then we'll close out by giving you the opportunity to ask questions and hopefully get good answers to those questions. Dr. Franklin.
All right. Welcome, everybody. Good afternoon. I'm going to start by acknowledging the strangeness of the way that we're doing these things these days remotely. I was having a conversation with my son recently before another webinar I was giving. And what I said, I was lamenting. I said, the one thing that's really hard is these days, when I make a joke, I don't hear anybody laughing. And my 17-year-old, who's known as being droll, his response was, but Dad, how is that any different than any of your other presentations? Which, point well taken. So suffice it to say that we're going to hang on to the questions till the end where we can have an exchange, because I can, right at this point, I can only see Josh, and that's not as helpful as reading the room as it would be seeing all of you. So thank you for joining us. And let me hop in here on affective education, and I will talk some first about the big ideas. Treating OCD and related disorders and anxiety disorders, there are critical elements. And really, you could go back as far back as Foe and Kozak in 1986, emotional processing of fear, exposure to corrective information, crucial. So the first thing you've got to do is you've got to activate the fear structure, which may or may not be hanging out in the cortex. There's some midbrain implications for fear as well, but suffice it to say that the cortex does contain some of these elements. So you've got to activate the fear. If I'm trying to teach you to be unafraid, me telling you not to be afraid is not so helpful. You know, stop being anxious is really not good advice to give anxious people, or people when they're anxious, because most everybody has a capacity for it. So learning the skills in the absence of the context of fear itself is not sufficient. I've got to practice while afraid. That is super important. So I've got to activate the fear, which means I've got to know what that fear is. So I'm going to spend a fair amount of time figuring out what that fear is, what situations will make it more or less present. And I'm going to try to kind of find that sweet spot between I'm anxious enough, but not so anxious I'm overwhelmed and going to avoid. So I need to activate the fear. And what's really important then is I activate the fear. Now what? So I activate the fear. I want to know up front what exactly it is that you think is going to happen. And then I want to really clarify that as best I can. And then I put the exposures are really exposure to the situations that provoke distress. And I want to circle back to what it is that you thought was going to be occurring and ask you whether it occurred. So I've many times in my life, I've been sitting on a bathroom floor with someone who said that within 15 minutes, they'd be vomiting if they were to do such a thing. And we're sitting on the bathroom floor after half an hour and the person's relaxed, if not bored. And I say, so what do you make of the fact that after 15 minutes, you kind of seem like you got less anxious? How can that be? What do you think is going on? So I'm providing an opportunity for them to think about this disconfirmation. So did the feared outcome occur? Or even if you were anxious, because I expect you'll be anxious, but were you able to function? Were you able to stay in the situation, able to manage what you needed to manage and stick around long enough to see what happens? And a huge question is, because sometimes people will say, well, if I go in this situation, I'll be anxious forever. And is the anxiety lasting forever? And it may be uncomfortable. You may, but I'm going to point out where I see anxieties changing. Disconfirmation's really important. I don't want to say, however, that gives me any guarantees for the next time. There are no guarantees. People ask me all the time, are you sure this exposure is safe? And I like my odds here, but there are no guarantees. And I also make the comment, the quip, and someday I'm going to be wrong. I like making the comment, well, I can't even guarantee I'm going to be alive in 5 minutes. And the patient, that usually gets people's attention. Like, are you feeling well? No, I feel fine, but I can't get a guarantee that I'm going to be alive in 5 minutes. I open the door to the possibilities, but I also want patients to recognize the difference between possible versus probable. So that's in the context of exposure. These are the things I'm looking to do: activate the fear, do the exposure, and then process with the patient and say, well, what do you make of it? Because I'm not sure this is consistent with what you told me in terms of the outcome we're seeing now. Okay, next slide, please. And depression. We've got to think a little bit differently and maybe a little bit more broadly, but I do think we have to activate it, if you will, quote unquote. We really need to make sure that we are dealing with the affect that the person is experiencing at the time, so we can test. Again, we're testing hypotheses here. And we've got to teach emotion regulation skills in the context rather than in a vacuum. If I'm talking hypothetically about how you'll manage your sadness and how you'll manage your pessimism and your low motivation, and at a time where you're feeling perfectly peppy, then it's not going to generalize to the situations in which you're maybe not so peppy. I need to be in that context in which this is going to occur to give you a chance to work on it in real time. Okay, so there's a disparity that you can also see between perception and reality. And was the predicted outcome correct? One of the things I'm looking for here, and this gets to the heart of behavioral activation, is patients sometimes feel not so motivated when they're depressed. Then they don't do things. And when they don't do things, the hole gets dug deeper. What I'm encouraging people to do with behavioral activation, which is one of our core treatments for depression in the context of the work we do at Rogers, is let's go find out. So you're telling me you can't do things. Let's go find out. Let's see how you do. And then again, here I'm turning back to this disconfirmation. So the person goes and they have an okay time at the party, or they go and they take a run, or they go and they play with their kids even though they don't feel like it. Then I can test the hypothesis. Okay, you told me before that you'd feel awful and it would never remit. How'd you do? Well, it was okay. And sometimes patients want to say, well, it wasn't great. Okay, no one's shooting for great. How was it? Was it as you expected? Was it as you predicted? If it isn't, it's suggesting that doing things when not motivated may prime the pump of motivation. And at the very least, it's better than sitting on the couch. We know for sure what's going to happen if you sit on the couch. You're gonna descend into the couch. At the very least, we want to give ourselves a fighting chance that things go better than we would expect. So was the impact of the outcome correct? So someone says it's going to take so much energy that I won't be able to do anything for the rest of the day. That's a common reaction, and then we can test that. So we got up, we took a walk this morning. I know you were worried about it sapping your energy for the rest of the day. We make a behavioral plan for activities we want you to try. And if you manage to get through that list, it's providing us again with some disconfirmation. And in the presence of that activated motivation and that activated behavior, do you wind up feeling better? Do you wind up feeling worse? We're testing all of it. I'm never promising people it's going to be fabulous. It may not be fabulous, but it's going to be, give us a fighting chance and perhaps be better than doing nothing. So something is better than nothing. There's all sorts of physics that I won't get into here, but the bottom line is I want to get objects into motion and people, because they tend to stay in motion once they get going, and that's the idea. So these are the kind of things we're thinking about with depression, and I think there's some parallels with anxiety. We certainly know that we have people who have not, I mean, this is maybe even the norm in adults, is anxiety and depression going hand in hand and often feeding one another. So this is going to make me really anxious. It makes me sad that I can't do it. And therefore, I'm going to just stay here and not do it. And then therefore not test my hypotheses about whether I would be anxious and whether my anxiety would dissipate. And my motivation is going to stay low because I chose in the presence of this discomfort to not confront it. Okay, next one. So we have this issue in ASD about alexithymia. And the really important piece here, the big idea in anxious or depressed folks with ASD, is they have a lot of fundamental difficulty with recognition of emotion even. How do I know I'm feeling something? How do you define it? We call it alexithymia, which is a fancy word for I don't quite speak this language and I'm confused. Communication. So even if you do recognize that you're having these experiences and they're negative, you may not be able to really put a fine-tuned point on it, but if you're having these experiences, they're also really hard to convey. So communication of affect is also a potential deficit in lots of folks with ASD, which if you'd imagine me sitting on the bathroom floor, I'll go back there, and the person's having a hard time either recognizing that they're anxious or communicating they're anxious, you can imagine those exposures being more challenging because I'm missing some information that I customarily would be getting with folks who don't have this deficit. But I have to figure that piece out, and Josh is going to walk you through how we might do that, both in the process of behavioral activation, but also safety planning. Because as you can imagine, if I'm trying to figure out if somebody's at risk and come up with a plan for risk, if they're not very good at understanding their emotions, then that whole process is going to need to be worked on in finer detail. We also think there's issues in ASD linking mood to behavioral urges and patterns, not recognizing that why you did something had to do with how you were feeling beforehand. And that's spend some time on, that you don't always have to spend that kind of time in the context of treating folks who are neurotypical. So the affective education we're doing in ASD that needs augmentation. So we do affective education in the midst of treating anxiety and depression anyway, but we need to make sure that we are activating the emotion. And these are in folks sometimes who go from 0 to 60 really quickly because they're not sufficiently aware of how they're feeling or how to communicate it. So we have to spend some time on that. And we also have to help them process disconfirmatory information. One thing I would say is I always put a little bit of a delay in this. When I'm working with someone with ASD, I'm not asking them so much when they're still anxious whether or not they have disconfirmation. I'm going to give a little space, because it generally is the case that their ability to communicate their affect and to hear and to understand your disconfirmatory discussion might not be as sharp as it will be if you give them a little more time to sit and when you know that they're looking like they're less anxious, okay, tell me how that was for you. I might wait a little longer with these folks just to make sure they've kind of gotten over the speed bump, if you will, before I start processing. My processing, I hadn't thought of it until we were doing this particular setup. And I think that is one place where it differs. If you were watch me do this treatment with somebody who does or doesn't have ASD, I think there's a delay on my end in when I'm going to start the processing of the exposure and the introduction of disconfirmatory evidence. I'm going to wait a little longer to give them more time to acquiesce, to get back to homeostasis, if you will, and then do this. I think that's an important and maybe subtle point. And I think that also will come in to be the case with safety planning. If someone's really activated, if they're flapping, which is usually a sign, you're not going to get much done in the midst of this. You want to give it more time, take your time, be patient. When they calm down, you can say, nice low tone. It looks to me, maybe this is the case, it looks to me like you might be feeling a little bit calmer right now. Is that right? And you want to use as much as you can. When people are escalated, you want to de-escalate. There's a really nice book out there written by a former FBI hostage negotiator. His name is Gary Nessner. And he wrote a book maybe 20 years ago called Stalling for Time, which was about going into and he'd been into the worst places you can envision, the Waco disaster and lots of other circumstances where people had lost control. And his fundamental premise was this: when people are escalating, you should probably de-escalate. So when I see someone's, and in ASD, you might get this kind of nonverbal signal that they're not picking up on, but you can. And I want to contribute everything I can in that circumstance to de-escalation. I'm going to watch my speech rate. I'm a New Yorker, so we're usually flying at one another. I really tried to turn into a Southerner, Mississippi porch on a summer Saturday, as Sean Mullins once put it. I'm going to be sitting there with a little mint tea and slowly and quietly responding when I see somebody is upset. I think in general, that's good advice, as Nestor mentioned, but I also think in the context of treating ASD and assessing ASD and trying to do safety planning, you got to pay attention to that piece. Okay, next one. So it's skill building. If it's a language they don't understand, we've got to really start to figure it out. And so one of the things that I notice a lot is I notice the leg shaking. So a lot of folks who get anxious and a lot of folks who have ASD, maybe even a higher rate of this, leg shaking, movement, nonverbal, sometimes it's this, sometimes it's the leg. And I can sometimes reliably see, even if they don't see it, I can see when that's happening. And what's good is if I start to notice that being consistent, so we're doing a hard exposure, the leg is shaking. Then I pull back, I give myself some time, the leg is not shaking as much. I go back to do a hard exposure, I see the leg again. I'm just one example of myriad examples. I might be able to teach this person, hey, you know what I've noticed, and you tell me if you've noticed this too, is that when you get upset that your right leg tends to really look like it's running a sprint. Have you noticed that? And they look down, sometimes they look down at the right leg and say, no, I've never noticed that. Okay. So maybe you want to pay some attention to that, because I've noticed it and I'm now trying to educate them about their own tells. Poker. This is a little bit about poker. And if this is not your language of comfort, reading the cues both from other people but also from yourself is not what you're going to do best. So I want to bring whatever I notice to bear as I try to educate them on how to do this. Basically, education about awareness of emotion, expression of emotion, and regulation of emotion. Expression of emotion, sometimes it's, is there another way to say that? Is there another way to convey that? So if you are upset and you start smashing yourself in the head, first of all, you're going to get a lot of attention for that maybe isn't the attention you want. Secondly, is there another way to express that to somebody so they get it? I know what you're trying to say, which is you're really upset. But when you start smashing yourself in the head, either with your fists or with objects, people are going to miss what you're trying to convey. So can we figure out a way that we can convey that some other way? And essentially, I'm asking to think about this as a voluntary process rather than it's just what I do. You get a lot of that with ASD. Well, it's just what I do. And I want to say, well, okay, is what you're doing effective? Because people start yelling at you for hitting yourself, now your message is gone. And you're going to wind up having an intervention that you maybe didn't plan on or want. And then teaching them methods to regulate their emotions and calm themselves down. I know we had it when I was working at Penn for 20 years, we had a little space. It was a very strange building layout. And it was this little space that we used to call the off ramp. Like it was a little like hallway that led to nowhere. And one of the affect regulation techniques we use, I told people, okay, if you get overwhelmed while we're doing exposure, you can head off to the off ramp. So you leave my office, you go down the hall, and you can walk, you can pace in this situation until you feel like that can calm you down. Because I've had too many people in that circumstance bolt and leave the building, which is really what I'm not preferring. If I know where they are and I know they're regulating and know they're learning how to regulate, I think we've conveyed something important and we've taught them another method rather than just running into the street. And when your office is at 36th and Market in the middle of Philadelphia, you don't want people running into the street. Suboptimal. So developmental scaling is basically how do I teach them to express emotion, to let me know where they are. And with the younger kids, I may be just sort of like in the pain clinic. I might be using the cartoon faces or figures, some other concrete expressions or gestures that convey emotion. Because if I ask somebody verbally, this is a verbally mediated process. If I ask you to do it verbally and that's not your game, that's not what you do best, I need to find some other way for you to convey it. And I certainly, I know Josh will get into this later, is sometimes when you tell somebody with ASD to rate their anxiety on a 0 to 10 scale, they look at you like, what do you mean? What's a 6? I don't know if I'm a 6. I'm a 6, I'm a 2. What does that all mean? So I got to find another way to get that across. With older kids, I might be interested in using their own interests. If they have a focus interest, if they love Spider-Man, if they love sports, if they love something else, how would you read this in a video game? How would you know a character is not doing all that well? So getting into the details so they can teach you how to teach them, a really important piece. And the content of the psychoed it's typical, traditional. We're trying to get the same stuff across, the sort of fundamentals of conveying emotion and understanding emotion and then expressing it and managing it. It's all the same. But the delivery's got to vary because of this context and because of the ASD interfering with your ability to do this sort of in the typical fashion. You've got to be really important. I think to be concrete is really important. If I'm going to use metaphors, I want to make sure I'm using their metaphors as opposed to some other metaphor that they can't relate to. We had one fabulous case where as a kid we were trying to get a sense of how a circumstance that he found very troubling. So he was in the dining room in his house, and he said, and it was interesting because it was always a dinner. Breakfast was fine, lunch was fine. Dinner, when everybody was home and everybody was sort of wound up, it had a little bit of more affect to it in the evening than it did earlier times. He said he would have intrusive thoughts of blood pouring out of the wall. So my therapist, who's an ASD expert, she's trying to find some different ways and metaphors. And one thing she said to him at that point was, well, what if it were grape jelly pouring out of the wall instead? Because the blood was obviously very disturbing to the kid, and he would leave. And when he leaves, he reinforces avoidance. And the kid looked at her and he says, Dr. McGovern, why would grape jelly be pouring out of a wall? That's the stupidest thing I've ever heard. And she fell on the sword, good citizen that she is, said, you're right. I mean, there's another way. You tell me what's a better way to think about this. And then from then on, every single session with him would start with, hey, Dr. McGovern, do you remember when you said that stupid thing about grape jelly pouring out of the wall? And she would acknowledge it, and they'd move on it was almost like a little ritual. Oh, remember then? Back in the good old days when you made that horrible mistake? Yeah, I do. Now I'm going to try to not make that mistake again. And it sort of added to the rapport. But I also think the point here is, if you're going to use metaphor, you really ought to make sure that you're using ones they understand and using ones that are concrete, and not trying to introduce abstraction, because abstraction is also not their game necessarily. Okay, next one. And I think for me, that's going to be it for now. Questions, as I said, because I can't see anybody except Josh, and he seems to be affable and shaking his head. He has no horrible things to say, I'm assuming, at this point. So I'm going to toss it over to Josh, and I'm going to be certainly around for the second part of the talk and for the question piece. Okay?
Thanks, Marty, and hello, everybody. As Marty told you, I don't get to see anyone. We can see each other. That's about it. I'm going to shift gears and talk a little bit about mood monitoring. So when we think about kind of the movement from psychoeducation into actually being able to assess what's going on inside our bodies, and we think about where we're going with safety planning, it kind of comes back to this idea that I can give you some great tools to use when you're very anxious, or when you're very depressed, or when you're very angry, when you feel like you're about to do something. I can give you some great tools for that. But if you're not really assessing, and you're not familiar with, and you don't understand the things your body is telling you, you'll never use those tools. There'll be some beautiful tools that sit in the toolbox not getting used. So we come back to something that is certainly not new, the idea of SUDS, which is a beautiful acronym for Subjective Units of Distress Scale, which that's why we call it SUDS instead of spelling that out each time. I want to point out that it's not just an acronym. There are several advantages to using a SUDS scale, no matter what it looks like. And as we'll talk about in a moment, depending upon who you're working with, that thermometer can look completely different. But the idea here is the same in terms of the advantages we're getting across. So first, when we talk about subjective, it's really important for us to understand that although we're looking for an objective measure of where things are, that measure is going to be different across people. So if you take any two people within the same situation, their reaction to it may differ, and the intensity of that experience is going to differ for them. So when we talk about this kind of the uniqueness of the experience that we're seeing, that's what's kind of tied up in this idea of finding something subjective. When we look at units and scale, and we kind of look at those two together, what we get is this idea that you can take something that's going on inside your body and you can quantify it. Not to get all, teacherish, but when we kind of talk about quantifying something, what we really mean is, can you put meaningful units to it? Can you somehow express that there is an amount conveyed when I talk about two different numbers, or two different types of food, or two different mood states of an elephant? So we kind of come back to something that Marty was mentioning earlier, which is it's helpful for us to be able to look into your special interests and what you find particularly interesting. I think traditionally folks tend to think of autism and special interests, and they'll think of things like Legos and Star Wars. And while we will certainly find kids and adults who are interested in Legos and Star Wars, it's important to understand that part of the reason those are such kind of popular common things is because they're pop culture phenomena. Almost everyone knows about Star Wars and Legos. But when you are talking about a kind of a population of folks, whether kids or adults, who have a certain area of interest for them and they know maybe far more about it or are much more experienced in it than most, you can find people talking about different types of train engine. My favorite actually was a young man who was with us who loved elevators. And I mean, like, I enjoy elevators, but he loved elevators, not just the writing in the elevators, but knowing the history of elevators, how the braking system in an Otis elevator works. I know far more about elevators now than I probably ever wanted to, how they move up and down, the different control panels. And so when we talk about putting a SUDS together, for him, it made perfect sense to think about the units and what we mean when we say emotions are going up and down in our mood state as an elevator car moving up and down in a building. And that really kind of resonated with him. And so that's really what we're looking for here. And then, you know, talking about the third thing last here, the distress. What I want to point out is that the SUDS is not just for anxiety. It's where you'll hear people talk about it the most, is anxiety disorders or OCD. We're really talking about distress or overall arousal. So in other words, something's going on inside your body. The pot's bubbling. How much is it bubbling? We could be talking about anger. We could be talking about sadness. We could be talking about joy. This could be a mania scale. It really doesn't matter which emotion we're talking about, so long as we're on the same page in terms of what that arousal looks like. I'm going to try and use this, and we'll see what happens. Perfect. So I'm going to give you an example of something that we tend to give to our adolescents and young adults who work with us in the program here. And what I want to point out to you is, again, notice as we step through that acronym again, when we're talking about subjective, what I want to know is what your anchor points are. So when you tell me that something is a 0 or a 10, what does that mean to you? What's going on inside your body that makes you say that? What do you notice? So you think about Marty talking about running a sprint with one leg and placing the chair. Maybe that's an anchor point for you that conveys that you are at this point on the magical scale. What brings your elevator car to a 7, you know, out of a 10-floor building? When we talk about the U for the units, what are your units? Again, is this height on a floor? Is this toppings on a pizza? Is this the spiciness of sauce that you put on your tacos? It could be anything that we're talking about here. Again, with distress, again, overall, not specific. Notice nowhere on this chart does it say anxiety or depression or anger. We're simply looking for anchor points. And in terms of symbols, so what do you want to use as the units? And then in terms of the scale, notice we kind of rely upon a thermometer. 10 years ago, I would have said almost everyone knows what this is. Nowadays, it's not often that you see people put a thermometer under their tongue anymore, but it's really hard to figure out how to convey a temporal thermometer or one that goes in your ear to put it on here and have the older folks like me know what that is. So when we talk about the graphic display, we don't have to use a thermometer. We could literally use anything to do this. So just something to point out in terms of what an example might look like of that. Something else that we want to talk about here is this transitory nature of mood. And specifically what I mean by that is, look, moods come, they go. One of the guys I used to work with used to say that they were like the ocean tides. They come in, they go out. And it will always come back again. If you wait long enough, your mood will change. One of the reasons that we have to address this is there are some pretty common beliefs across presentations, whether you're talking about anxiety, depression, anger, anything that you can think of. When people are feeling poorly, I think feeling badly is probably a grammatical error, but feeling poorly, whether it's anxiety or depression or what have you, there are these beliefs that start to come to the forefront, assumptions that we make that we may not even be aware of. And the 3 that I specifically want to get into are that this thing I'm feeling that's yucky right now, I always feel this way. So there's this belief or this thought. The second is that, it doesn't really matter what I do. Nothing's going to change how I feel in this moment. So in other words, if I feel this way, I'm going to feel this way all the time, forever and ever. Amen. And then third, not only do I feel like I always feel this way and there's nothing I can do about it, but something's wrong with me because I feel this way. There's something different about me. Other people don't experience this yuckiness. It's just me. Or if they do, it's somehow different than how I feel. What I want to point out is that a great way of tackling these thoughts, a great way of tackling these kind of internal beliefs that we see people have is by using the SUDS. So what do I mean by that? So if we start with that first one, this is how I always feel. I want to point out an error that we make a lot of times in clinic, and as a societal error, I guess. I don't know that I want to go that far down the line. But one of the things that we will always say is, how was your day? And man, if you ever want to know the definition of a summative evaluation, there it is. You get one shot at this. Tell me how the entirety of your day experience was in 3 words or less. Go. I want to point out that there's kind of 2 errors that we see. So when we do check in the morning, when kids or adults will come in and we'll ask how their day was, tell me, was it a good day? Was it a bad day? 0 to 10, where was your day? We will see 2 different things. And the examples I use here are spilled my drink. So we will see kids or adults that will come in. Kids are the most fun because of their parents. They will come in and we'll ask, how was your day? And they will tell you, like tears running down their face, they will tell you that it has been the worst day ever. They don't want to live anymore. I don't even know why I'm here. I'm just going to go home. I want to hide underneath my desk. And their parents will look absolutely shocked by this. They don't know what to do with that. And so when you talk to the parents, what you will find is that they did really, really well. Maybe they did a lot of the homework that we asked them to do. They tried something different. Maybe they tried a new food. They introduced themselves to someone. They set a play date. They applied for a job, whatever it may be. And they were having a great day. And, the parents are all very hopeful about this because there's been this tremendous change. And then 5 minutes before session, when they got out of their car and were walking through the parking lot, they spilled their drink on their new shoes. And that now is what is going on up here. When I ask, how was your day? We're focused on something that happened 5 minutes ago, and we've discounted the last 23 hours and 55 minutes of our day. By the same token, almost as entertaining, but a little bit sadder sometimes, is kids will come in and you will see the parents with like the bags underneath their eyes. They can barely stay awake. We'll ask kids how their day was. And the kid will give you a huge grin and be like, I had a great day. This is fantastic. And you might notice that, the parent starts to tick a little bit and they're not really sure what to do with that information. And it turned out that it was absolutely an awful day. Everything that could have gone wrong went wrong. Nobody slept. No one was happy. Everyone was arguing. There were lots of tears. Okay, hopefully no bloodshed, but a lot of tears. And then on the way into session, their favorite song came on the radio. And it turned it around. And again, what's going on in their mind when I ask, how was your day? How did things go since the last time I saw you? I get that 5-minute period of experience. And we've discounted the last 23 hours and 55 minutes. So my point in this and telling these stories is that when we use summative evaluation to ask about mood states, one, it's really difficult and prone to way too much error to ever be an accurate kind of summation of what's going on in someone's day. You're talking about folks, and let's talk about kids in general, but particularly kids on the spectrum and a lot of adults on and off the spectrum who tend to live moment to moment when it comes to mood state. If I ask you what's your temperature, they're kind of metaphorically going to take their temperature in that moment, and that's the response you will get. There's not a lot of attention paid to or record keeping going on of my emotional state over the last day. So a few barriers that we run into here are this kind of limited insight into what I'm asking you and why. And kind of some perspective taking difficulty in terms of kids may be quite confused or adults may be quite confused. If you ask, how did treatment go today? And everyone in the room thinks you had a great day of treatment and it was a fantastic session. And someone said something sad, or one of the other people in the program is discharging today and you won't see them again. And now you're very sad and you tell us that you had an awful day. The kiddo or the adult that we're talking about here may be quite confused by the fact that we're stunned by that report. And so there's kind of this mismatch that we'll find. Some other problems that sometimes we'll see is we can call them attention deficits. I don't mean kind of like formal ADHD type attention deficits, but here there's this kind of idea that I'm going to pay attention to what's important to me in the moment. And what's important to me as your therapist may be quite different than what's important to you as my patient or my client. So when we kind of talk about all these things that can work against us in the moment, when we ask about mood ratings, it's very important, in this moment when we talk about getting mood ratings, that we get many of them, that we get them throughout the day, and that we're in some fashion recording them to later on reflect back upon. So probably way too much time spent on that slide, but it's an important point when we kind of talk about using this in a formative way rather than a summative way to get a record throughout the day. When we move into safety planning and we kind of think about what do we do with folks who quite literally are having an awful day or an awful series of day, and we find that mood is very, very high. one of the first things that I want to come back to is this idea of using the SUDS as a decision-making tool. Okay, so here we come back to that second thought error that we discussed, which is that nothing, no matter what I do, nothing's going to make me feel differently than this yucky way that I feel right now. So I'll point out that the SUDS gives us a great way to link emotional arousal, if you will, so kind of where you are on the scale, and what your behavioral response is in that moment. And many times, particularly in anxiety and depressive disorders, when folks are coming in to see us, one of the presenting concerns doesn't have as much to do with the emotion as it has to do with that mood or that emotion is driving our behaviors. So we're engaging in what we would call mood-driven behaviors. So if I feel poorly, I'm going to tend to do things differently and do different things than I will when I'm feeling well, or when I'm feeling happy, or when I'm feeling calm or relaxed. So what I'll point out here is, regardless of what the units are that you choose for a SUDS, and regardless of what your scale looks like, we can kind of roughly categorize the SUDS into three rough regions. The first being the low region towards the bottom, or the left, or whatever you may be using, the less toppings on your pizza, perhaps. And the idea here is that when I'm experiencing this mood state, I may be experiencing a little bit of distress, a little bit of arousal, but I don't need to change what I'm doing. I can keep going, and I also want to keep monitoring how I'm feeling to see how that changes over time. When we kind of drift up into the middle, where there's a little bit more arousal going on, here we get to a point where, not only is my distress noticeable to me, it might actually be noticeable to other people around me, particularly those who know me well. At this point, I want to kind of double check the situation around me. So I'm going to stay in the moment. It's really important that I kind of focus on how I'm feeling at this point and what's going on around me. And I'm going to use a series of coping questions, and we'll talk about this in a moment. Then when we kind of shift into that upper third or upper quadrant, or whatever you choose to use for your scale, this is where we're feeling overwhelmed. And I think there's an important point here, and we'll talk more about this later. But what I want to point out is emotions aren't dangerous, right? So when you're experiencing a high level of distress or emotional arousal, it's not that's going to get you into trouble. It's what you feel as though you are likely to do, or losing control of your behaviors because you feel overwhelmed, is typically what gets us in trouble. So at that point in time, our behavioral response tends to be that if I feel as though I'm going to lose control, it's okay to take a short break, to step back, kind of reorient to what's going on. Maybe I'm going to ground myself. Maybe I'm going to distract myself with another activity. And then I'm going to re-engage in what it was I was doing before when I noticed my arousal levels coming up. So again, I'll link over to something else here. It's another kind of a handout or a worksheet that we tend to give adolescents and young adults. And what I'll point out here is, again, we're linking this emotional state or this mood state to behavioral responses. So notice the low down there at the bottom. So you can see that some examples that are given, some common ones. And we also ask people to give other examples from their own lives, or things that maybe just get on their nerves a bit, that get them a little bit of arousal, but not a tremendous amount. And then what do? We sit with it, we keep an eye on our feelings, and we keep going. Notice when we shift to the middle, here are some other examples given where maybe my mood state's higher. I'm feeling a pretty considerable amount of distress. Maybe other people are becoming aware that I'm not as happy as I could be right now. We look for other examples of that. Notice the what will I do here. We have this beautiful series of coping questions. You don't have to squint. I'll show them to you in a larger version on the next slide here. We're going to step through those coping questions, and I'll show them to you in a moment. And then we want to proceed. And again, we want to keep doing what we're doing, knowing that mood is transitory and that it should crest and reduce and subside. Then we get into the high range here, where again, what are some things that typically tend to bring our mood state that high? And we ask for other examples. And then what we want to do is get kind of written down so that they're there as a ready reference. What are the things I'm going to do as I step away? How am I going to reorient myself? How am I going to bring that level of arousal down? And then once I do, it's important for me to re-engage again and constantly be checking what my mood state is. So again, I just want to show a brief example of that. As promised, when we talk about decision points here, so the low, the keep going, keep monitoring piece, this really should be the default position. And something interesting that we'll run into, and this is not limited by any means to people on the autism spectrum, is that many people, when we ask about mood states, you will get some folks who will always tell you that it's closer to a 0 no matter what is going on, right? The room could be on fire and they'll be like, okay, I guess I'm at a 1 out of 10, right? You will also have other people who the slightest perturbation, right? The slightest change from whatever the homeostasis that Marty mentioned earlier, suddenly we're at a 10 out of 10, right? If it's a 0 to 100 scale, I'm at 100 now because something has changed in the slightest. So it's very important that we kind of start using some skills and some examples to help people stretch that scale out so that we get it to be a meaningful scale to them. A 0 to 10 scale is not helpful for you if all of your emotional experience is going to reside between 0 and 1. By the same token, it's not going to be a particularly helpful tool if you are living 95% of the time between 9 and 10. We have to find the range that works for you and then subdivide that into danger, Will Robinson, the moderate level, and then that low level where we just keep plugging away. So notice that in the middle here, when we talk about the coping questions, so first thing I'll point out here, as the smiley face would suggest, there's kind of a disturbing trend in coping question acronyms among psychologists, and that probably speaks to something deeply wrong with most of us. But if you make some poor choices and you read anxiety or depression coping manuals, you will find very quickly some of these questions that we see. So the first one that's up there, the kick, actually comes from something called the Biaka manual by Dr. Wood. And that K is knowing when I'm anxious, right? So knowing what I'm feeling, what's going on right now. The I could be icky thoughts if you're talking about younger kids. It can be irritating thoughts if you're talking about adolescents or even adults. And so there, what we're kind of getting at is, what's the worst thing that you can imagine happening right now? The calming thoughts, which is the C, what we're really looking at there is, has this ever happened before? Like, what are you going to do if it happens? If it's never happened before, how likely is it, right? And then once we've kind of figured this out, we come back to what Marty mentioned earlier, which is we approach this as an experiment. So that last K is kind of a cheater step, right? It's keep going, keep practicing, keep doing this over and over until it becomes knee-jerk to you. So notice that in the moment when I'm checking in with what's going on around me and I need to see whether this is reality or this is just my perception of reality, these are the questions I'm asking. The second acronym there, FEAR, comes from the Coping Cat workbook by Dr. Kendall and colleagues. And there, really kind of what we're looking at is really the same process. It's just a different acronym. The WHIP, which sadly probably the most disturbing of those, is the one that I came up with that we use for our program here at Rogers. And here, what we're looking at with the W is, what's the worst that could happen? The H is, has it ever happened before? Yes or no? So you'll notice we're on a familiar ground here. That third letter, the I, is if yes or if no. So if it has happened before, what you're telling me is you know exactly what to do if this thing that you fear happens. And in fact, what you're also telling me is you somehow managed to survive this feared outcome. So that means that we know what to do, and let's get on with it. If you're telling me it hasn't happened before, not only do I want to know how likely you think that is, but I want to know, what do you think we should do about it if that does happen? Let's get a plan together. And then once we either know that we know what to do or we have a plan for what to do, we come back together at the P, which stands for proceed. Okay. So you'll notice a kind of a similarity and a resonance that goes across the coping. And we come back to this idea of understanding that I'm aroused right now, that I'm experiencing some distress, knowing what that's about and what it is that I fear or what it is that I don't like about this situation, coming up with a plan as to what to do about it, and then keep on plugging along, right? We want to proceed or keep practicing. When we talk about when a safety plan is necessary, so one thing I'll say is this is a little bit of a trick question. And the reason it's a trick question, to me anyway, is when I think about how our field a lot of times approaches safety planning, I think sometimes we view it through the wrong end of the telescope. And here's what I mean by that. I think a lot of folks see a safety plan as a, in case of emergency, break glass thing that we don't want to have to use, but if I have to bring out the big guns, here's the safety plan and this is what it's going to do. And we use it to avoid something. In my mind, when we think about a safety plan and how we should be using it, it's yet another tool in a box. And when we think about the skills that we're trying to teach kids, adolescents, young adults, old adults, on or off the spectrum, when we talk about a safety plan, what we're really talking about is when I start to know myself and I start to get an idea for what my tells are and the things that are a danger that I want to look out for, what am I going to do in that moment? And then I constantly want to be assessing to see where I am. So yes, that plan is there, but if we treat it as something to only be kind of brought out in an emergency and blow the dust off of it, it's not going to be very effective. And if we're honest, when we think about what we talked about earlier, which is that I'm living in the moment and it's very hard for me to kind of think back to what's happened before, it's not going to occur to me to go for the safety plan when I'm living in the moment for right now and what to do. Okay, so when we think about CBT, which is what we use at Rogers, which is what a lot of people use, which is, I'll point out, the gold standard for treatment of anxiety and depression, it's a skill building approach. That is exactly what therapy is. Therapy is not fixing what's broken. Therapy is identifying skills that either aren't present or need help, and we either want to instill those skills and or we want to have you practice them to competence, if not mastery, so where these things become automatic for you. So when I say coping, the first word that should come to mind for you would be skills. So when we think about emotional identification, when we think about how we're expressing to other people what we're feeling and what our mood state is in the moment, and when we're thinking about how to regulate particularly strong, intense, or negative mood states, these are all skills. You may think that you were born knowing how to do this. I promise you, you weren't. But the nice thing about a skill building approach is no matter who you are, we can build those skills. So when we think about the safety plan through this lens, it is nothing more than an organizational chart. It's an easy reference to skills that we're working on. So what's my emotional status? We come back to emotional identification. We come back to where am I on the scale right now? Am I distressed? Am I not? And if so, how much? How can I keep things from getting out of control? What are some ways that I can express to other people how I'm feeling to kind of let them know, and that I can become a little bit more reoriented to what's going on around me, maybe a little bit more grounded, but also checking reality. And finally, if things do start to get out of control for me and I'm living on the high end of the scale now, what are the things that I'm going to do? How am I going to regulate those emotions? How do I take a break, step back, reorient, and most importantly, re-engage in the moment? Okay. So when we keep this in mind and we think about it from a skill building approach, there are actually 7 elements that go into a safety plan. And while safety plans will look different for any individual that you're working with, they have to, they're all going to have these elements if it's a good safety plan. So the first one I'll point out here is this unsafe or kind of target behaviors or symptoms. So in other words, what are the things that I need to be on the lookout for that I don't want to have happen? What are some things I don't want to do or an outcome that I don't want to have? Okay, once I've identified that, what are my early warning signs? So maybe we come back to what Marty said, which is that, oh, there goes my knee. Now my leg is jumping up and down and suddenly we have an earthquake going on here. So when we kind of think about what those early warning signs are, that maybe I'm the only one who noticed, maybe my chest hurts, maybe my stomach doesn't feel very good, or I'm starting to get a little bit of a headache, or I notice that my hands shake. Maybe those are my early warning signs. In that moment, in the presence of those early warning signs, what are the actions and what are the tools that I can use in that moment to address those early warning signs and to bring that level of arousal back down? Notice here, what we're really talking about are kind of self-care activities and prevention techniques, right? The next element that we want to talk about are still early warning signs, but these are ones that other people might notice. So maybe I notice that the volume of my voice is going up. Maybe I notice, if it's what I do, that one of my ways of kind of venting off that extra energy is to engage in self-stimulatory behaviors, right? Maybe I'll start flapping or rocking. Maybe, you know, one of the things that I do is to maybe slap my forehead a little bit because that kind of helps me keep me in the moment. If those are early warning signs that things are starting to cruise up into that middle zone, these are things that other people are going to notice in addition to me noticing them. What are some actions and tools that the people around me who know me well or that I spend a great deal of time around can use to support me in that moment? Whether to bring it to my attention, to provide some support to help me take a break if I need it, or to provide some support to be able to push through a hard moment in time. And I mean, there's another lecture to be had on the difference between accommodation and support, and that's really kind of where this comes into play here. We always want other people supporting us, not accommodating us. And then we kind of get into, again, on the high end of the scale, what are the signs of trouble? So when are things approaching a crisis point where we really need to kind of take a look at some steps where maybe I can't keep myself safe in this moment. I can't make good choices in this moment, but I'm probably very good at making bad choices in this moment. And so what are those signs of trouble? Maybe I'm screaming, maybe I'm crying, maybe I shut down and laid on the floor, maybe I pull my hair out, maybe I begin pounding on the desk or throwing things. What are those signs that things have kind of gone beyond my ability to control them? And in that moment, what's my path? Who do I contact? What are the resources available to me to keep me safe in that moment until I can allow that mood to pass and I can reorient and re-engage and work my way back down this list. So 7 elements that we talk about here. And again, you know, I love to give you examples. So here is an example safety plan that we actually will use. Again, I'm pulling these all out of our adolescent and young adult manual. The reason for that is because I think a lot of people have seen resources that are used for the younger kids. There aren't a lot out there for adolescents and young adults. I'll also point out that this is not a great deal different than what we would do for a younger kid. It's just that we usually have their parent or their guardian or their caretaker or someone else also heavily involved in the safety plan, the younger that you are. So again, notice when we talk about this, the one thing I will apologize for is, although I have the unsafe behaviors and symptoms listed as number 1, it's actually the second thing on here. And that's because what we're looking at is, why do I care about these early warning signs? Because they could be signs that I'm heading toward these things that I want to avoid. So you'll notice here some examples that when I notice that I'm feeling anxious, worried, or irritable, maybe I'm beginning to pace, maybe I'm hitting myself, maybe I'm having thoughts that I'm a waste or a failure or the world would be better off without me. In that moment, what am I going to do? Well, maybe I'm going to use you know, deep muscle relaxation. Maybe I'm going to use respiratory techniques and breathing strategies. I'm going to listen to the music that I like. If I'm home and it's accessible to me, maybe it's a bubble bath time. I'm going to call my parent. I'm going to call my sibling. Maybe I have a kit, right? Like a crisis kit that I've got, and I can pull that out and it has my go-to stuff in it. Maybe I have a distress protocol that I've been working on in treatment in terms of a step-by-step plan for what to do right now in this moment when these things are present. Now, as we kind of work our way up, I know I say working our way up as we work our way down the paper, when other people become aware of some of these signs, so maybe I'm crying, maybe I am irritable and angry, and that's not normally who I am. Maybe I didn't show up for work today, and it's the first time I've missed work in the time that you've known me. Maybe I spend a lot of my time lying in bed, and that's not usually who I am. Okay, these are all should be warning signs or kind of signs that something's not right to the people around me. And in that moment, what do I want other people to do? If I can come up with these things of other people acknowledging how I feel, other people asking what they can do in the moment, other people reminding me to use the safety plan and to try some of these skills that maybe I stepped over up here, these are the things that other people can do to help us be successful. When we identify things within this block here for what we want others to do, this is where we can begin to let other people know ahead of time, hey, when you see these things, I'd really appreciate it if you could help me by doing this. Now notice we're into the crisis or the serious trouble signs. If I start feeling as though I'm going to hurt myself, or I actually do begin engaging in self-harm behaviors, maybe I feel as though I don't care about anything anymore and I feel like I want to go to sleep forever. In that moment, what do I do? And usually what we'll find here on this example, it doesn't have it normally, this is a bulleted list. Because if you imagine that at the time that you feel that way, it's difficult to pull things out of a paragraph. It's a lot easier to usually follow a bulleted list for this. And then additional notes down here, I'll talk about this in a moment as we kind of talk about how to make this more effective. But again, I wanted to show you an example of something that we put together. In terms of kind of safety planning and how do we make this more effective? How do we make this something that not only is a safety plan, but your safety plan, and not only your safety plan, but a really good safety plan for you? The question I ask is, how good is this plan if you can't remember what's on it? And again, we come back to the idea that this is a skill building exercise. And the only way we get better at riding a bike is to ride a bike more often. Another way of thinking about that is that, you know, if I drive really poorly, I have two choices. I can either never drive again, in which case I probably won't get in another accident, at least one that I've caused, or I can take driving lessons. There's kind of two different ways of looking at that. And when we think about an effective or an enhanced safety plan, what we really want to do here is we want to take that second option. I want to learn to be a better driver. I want to learn to be better at engaging myself and engaging my mood state in the moment and having control over that. So kind of three different things that we want to think about here. And the first is the ease of recall. So how easy is it for you to remember this? And there's two different things that we'll look at here: how the safety plan is designed and overall practice. Okay, so when you think about the flow of information, notice that although when I listed the 7 elements, kind of conceptually, it makes more sense to think of what's the outcome we want to avoid and putting it first. In the safety plan, it's more of an if-then type of a statement, or a why and because type of a statement. So here, how we design the information to flow makes it easier to remember in the moment. The other thing that makes it easier to remember that thing in the moment is to practice those skills over and over. And like we said at the very beginning, when Marty was talking about the fact that it's futile to practice emotional regulation skills when you're calm and copacetic and everything is cool. For those of you who have ever done like couples counseling or marriage counseling, I can give you great conflict resolution skills. And we can practice talking respectfully to one another in my office. But if I don't push your buttons and make you mad and get you irritated at one another and then have you practice using those things, then you're going to do great in my office. And then I'm going to get a crisis phone call because on the drive home, one of you irritated the other, and now somebody's walking home while the other one sped off in the car, right? The same thing is true here when we talk about using enhanced safety planning, or how do we make a safety plan more effective. I have to have you practicing using these skills when things get real. If you find that you are agitated, if you find that you are anxious, if you find that you're, feeling really yucky, that's when we need to be practicing these skills. So what does this mean in terms of therapy? That means that part of that therapeutic time, and this works really well when you're doing exposures or behavior activation, is I need to on purpose be putting you in situations where that arousal level is coming up so that you can practice using these skills. When we talk about the ease of being able to use the skills, these have to be individualized. I'll say it again, no two safety plans look identical. There are some that are pretty close, but everyone is suited to the individual, okay? And the reason for that is that there are, if you've ever been to a bookstore and looked at some of the mindfulness or coping skills or grounding skills books, there are thousands of them. There are so many skills. And the key here is that I can pick up a book full of mindfulness activities and not all of them are going to be applicable to me. I'm not going to find all of them attractive. I'm not going to find all of them useful. I'm not going to find all of them effective. I'm not going to want to do most of them. I have to find the ones that work for me. So part of the relationship that we get into with the therapist and patient, or therapist and client, however you think about that, is I have to find those skills. Well, how do I figure out which skills work for you? I have to have you practice the skills. Why do I bring this up and make such a big deal out of it? You need to help your clients or your patients manage their expectations with these skills. I have 10 coping skills that I'd like to take a look at. I can tell you right now, there's going to be some that don't work, but the only way we find the ones that do work is to step through them. That way, if I have you practice a skill and it doesn't work for you, you don't just wad up the entire list of 10 and chuck it and decide not to do that again. I have to help you manage your expectations with regard to these skills and finding the ones that work for you and the ones that you like. And then the last is the ability to access these, or ease of accessing these skills. Notice I don't mean the same thing here in terms of remembering. I mean in terms of, when things get real in the moment, what do we do? So there's a really funny term we use called stimulus control. And it just means, what are some things I can put in the environment around you that will get you kind of triggered in a good way, that will kind of bring you back to, oh yeah, I need to use my safety plan in this moment. So what do I do? How do I make sure I have access to this list when I need it? Maybe I have you keep a copy of it on your phone if the phone is what you carry around. If you're never to be found without your iPad, maybe I put it on your iPad. I guess I should say tablet. I didn't mean to give Apple a plug there. I want to put copies of this safety plan where you're most likely to need them in the moment. There are also some great applications out there. I did not link to them only because I like to remain relatively agnostic about it. But if you look online, and particularly if with your patients or your clients, you look online and look through the app stores for your various devices that you like, there are a lot of applications out there that allow you to build a safety plan that works for you. And some of them are pretty kind of creepily smart, and that they'll do things like through the watch on your wrist or your Fitbit or whatever it may be, they will begin to monitor things like your respiration and your pulse. And maybe it'll give you a thump and say, hey, is everything okay? Maybe you should try whatever the coping skill was that you entered here. My point in all of this is that there are various strategies that we can use that make these plans easier to remember, easier to use, and easy to access when we need them. But notice that for all three of these, it's all about practice. And until we practice them again and again, we can't be sure that you're going to remember them in the moment. So when we come back to a question that I asked on the previous slide, which is who should get a safety plan? Believe it or not, in terms of how I think about it and in terms of how we do things with the patients here at Rogers, every patient has a safety plan. It's not because I expect them to need to activate crisis skills. It's because I want to have that plan set out so that when the time comes that should they need it for some reason, it's something they've practiced. It's something that is a knee-jerk reaction to them. It's something they know as well as they know anything else, and it's merely one more skill in their box. Notice that this also kind of gets at this idea of there's something wrong with me because I feel this way. If we only give safety plans to people that we think are likely to need them in the immediate future, it's kind of another way of stigmatizing people. Particularly here, when we think about folks who are together in groups, it's kind of like being in a classroom at school, and that maybe you're getting the services you need, but if we pull you out of the classroom to give them to you, we can actually inadvertently stigmatize you because everyone else wants to know where you went. Everyone else in treatment wants to know how come he or she gets a safety plan and I didn't, or how come I have a safety plan and they don't. And I think it's very important that when we talk about kind of practicing these skills, these are skills that everyone should use. Everyone should be able to recognize their emotion. Everyone should be able to express them appropriately, and everyone should be able to regulate them. And if you can't do those things or you're experiencing trouble with them, it's simply a skill that we need to work on. Enough about that. At this point, I'm going to turn this back over to Christine for the question and answer period.
Great. Well, thank you so much. That was great. So if you do have a question, please use the Q&A button on the bottom of the Zoom taskbar, not the chat feature. And we'll try to get to as many questions as we can in the time we have left. And if I don't get to your question, please just send me an email afterwards and I'll follow up with you. So let's get started with questions. First one. How do you respond if the client's feared outcome does actually occur?
Marty, do you want to touch on this? Because I love how you explain this.
Sorry, I was muted. What were you saying?
I said, do you want to touch on the answer to this question? Because I love how you explain what do you do when you're working with a client and the thing they're afraid of actually happens.
Yeah. Well, I mean, first of all, I make room for that possibility by never giving any guarantees. I like our odds, but we'll have to see. So I'm setting up that way. And in fact, we have a virtually now annual presentation at the ABCT meeting, which is, and the title of this, it's a panel discussion with experts that have seen these things happen. And essentially its title is When Exposure Goes Awry, because trust me, it's gonna at times. And again, the first thing I want to do is I want to acknowledge that it's possible. So I never give people, what's the old song? I never promised you a rose garden. I never promised you that everything would go smoothly. I want to really understand though, when I'm in the middle of an exposure, what is the feared outcome? I can recall one particular exposure. It was an adult who had tremendous fear of parking and leaving her car, and that it would be stolen, especially in the city. And I'm right smack in the middle of 36th and Market at the time, which is West Philadelphia. And she had a vision that your car was going to be stolen with you in it, pretty much. And so what we did exposure to practicing, because she was checking her car repeatedly, which is where this became an OCD thing, not just a worry. So I had her checking the car, locking it only and clicking that button, and we'd walk around the corner and come back. We must have done this 20 times or so. The 21st time we come back, she puts her hand on the door and the door opens. So she opens the door and she says, "Oh my God, I told you." And me, you know, I'm very mindful of what she did tell me. I said, "You told me what?" She said, "I told you if I don't check, this would happen." I said, "Hang on a minute. Like this, as in the car would be open, or that the car would be stolen? Is the car stolen?" No. Okay. So then that's still consistent with the model. And I said, as a person who lives in West Philadelphia and has many times left his car not only with the doors open, but with the windows down overnight, the worst case scenario for me in those circumstances was a lot of rain. I left the sunroof open too, which was really clever. And so what I would say is that this is not an example of your fear coming true. But there are certainly times when the fear does come true. I've had a couple of emetophobia cases who go back into school. They're getting used to being around other kids. And one particular kid in 4th grade turns the corner, and here's one of the classmates hurling in the hallway. And then, okay, so this was not a planned exposure. What do we do now? And then the answer is we kick back into that model that we decided that we were going to use, which is leaning in, not away. So what's a reasonable thing to do in this circumstance? Probably not to walk through the vomit, but it's also not to sprint to the principal's office and ask for a ride home. So if we anywhere between those 2 points we can wind up, then we can still have a success. Exposures do sometimes go wrong. And I could regale you with more examples, but the bottom line is I'm going to hold firm to this idea that this is, whether it's disconfirmatory or not, I'm going to say, look, we don't have promises here, but we want to cope. And anxiety is really, to me, and Foe and Kozak did some good work on this, and subsequently in social anxiety, Edna and I did some studies looking at these issues as well, which is it's comprised of the probability and the cost. So the probability is how likely is it this feared outcome will happen. We were asking social anxious people, how likely is it that people will ignore you or cut you off? And that's only half of the equation. So how likely is it? And in social circumstances, these things do on occasion occur. I don't want to tell people it's going to go fabulously well. Everyone's going to find you oh so interesting. Maybe they will, maybe they won't. But what's the cost? If it goes badly, what's the cost? How much does this affect your life? How much does this affect your job prospects, etc.? So I want to make sure I'm looking at both pieces. So if it does occur, fair enough, but what's the result of that? And I want to make sure I'm looking at both things. But I'm acknowledging up front that there are no guarantees, and at the same time, I am very mindful of staying on message and keeping my tone where it needs to be.
Thank you.
Okay.
Okay. Next question. What methodology or curriculum do you use to teach individuals with alexithymia how to identify emotions?
That's a really good question. I mean, I'll jump in, and then I'm sure Marty may have more to add to it. There's not a set curriculum that I use, so I don't use a prepackaged curriculum for that, because typically what we will find is that there's a lot of different ways that this will show up. So it'll another way, a geeky way of saying that is that it manifests differently across individuals, right? So there can be two different people who maybe score quite highly or find that they have extreme difficulty with alexithymia, but it can show up in different ways. So for some people, they may not at all understand the sensations that their body is giving them. They may not understand that, that they're really grouchy and they won't put it together with the fact that they haven't eaten, that at all that day. Or they may find that, that they're waiting on the time to be done to go to recess or to take a break at work or to take a break from treatment, and they are clock watching. And what they will find is that, the closer they get to that, they may not realize that their level of arousal is coming up, but they may feel like they're getting yelled at, or they may feel like they're getting a lot of negative feedback because they're getting so fidgety and, and anxious and ready to go that people are having to tell them to dial it down a bit. By the same token, someone else may not at all be aware. So they may be experiencing something completely severe on the inside, but no one would ever know from the outside that that's what's going on. And so it can be very difficult to decipher that. So when we kind of talk about how we teach these things, kind of what I'll say is the way that I typically will start is with a positive emotion, specifically happy. That's the one I like to start with. And so in terms of, when you think back to a time when you were really happy, and what I would say is kind of pick something that typically tends to be as close to universal happy thing as you can. So when we think about things like, tell me about your favorite birthday. What was the party like? Who was there? What did you do? What did you get? What did you like about it? And as I get you talking about that experience and what was going on that day, the things that I want to ask are, do you remember in that moment, what did your body feel like, right? Like, not to be a serial killer, but if I popped your body open and looked, what would I see going on? Was your stomach all knotted up and tense? Were your hands shaking? Was your heart beating really a lot? Were you in pain? What was that like? And when I can get people to kind of focus on what was going on inside their body while having an experience they enjoyed, the reason I like to start with happy is one, it doesn't tend to be a scary emotion. And two, if we can get that one down, the rest of them are a little bit easier. Because I can say, well, what's it like to be anxious? And they'll say, I don't know. So we think about a time when you were anxious. Like, let's talk about a time when the teacher called you up in front of the classroom because you were doing something you shouldn't have been, and they were talking about how they were going to call your parents, or how you were not a good person, or whatever it may be. Or maybe you got fired from your job. And we think about that. If I ask you what that felt like and you tell me you don't know, many times I can reflect and say, well, did it feel the same as when you were happy? So like when you told me that, you know, you had little butterflies in your stomach and you felt light in your shoes, and like every step you were kind of bouncing when you walked, was that what it was like? So what I'm really kind of helping you do is start to pick up what's different about two different emotions. So that's kind of where we start, is with what are the things that are going on inside your body that you can feel. And then kind of the next step as we start to have you link those up is, again, we come back to something Marty discussed, which is what are your tells? So when you're feeling those things, how might I be able to tell that you're feeling those things? What are some things I can see? Do I see you smiling? Do I see you talking to me when normally you don't? Do I see you shutting down when normally you do talk to me? So it's kind of a very generalized approach to doing it. And there are prepackaged curricula out there for doing it. But I don't want to say that they're bad. It's just that I've always kind of been more of a take it to the patient and kind of figure out who the person is that you're working with and try to individualize it to their needs. It's a really good question. Marty, did you have more to add to that?
Yeah, I mean, it's a nuanced question, and it gets to the heart of manualizing versus tailoring. And if I'm manualizing it, sometimes the impression people have from manuals who don't use manuals a lot is that they're cookbooks and they're going to tell you exactly what to say in these circumstances. And that's not how I view treatment manuals, at least not the good ones. The good ones are going to give you the core theory and then the principles and then a million examples of how you can tailor. And sometimes your tailoring is going to be so specific to an individual patient in front of you that it may not look anything like that when I'm doing it with a patient at 3 o'clock that I was with a patient at 4. I can recall an example doing a randomized controlled trial in which I was one of the study therapists. It was an OCD trial with adults. And when you're doing efficacy studies, they're painstaking checks on methodology and on fidelity to treatment. And so one of my tapes got randomly picked by the research assistant to be reviewed. And so the research assistant, who's an undergraduate level, who hasn't done a ton of this treatment and probably doesn't at that point recognize these kinds of specifics and nuances, she picks my tape. And I get a note from my supervisor, Michael Kozak, who is all business. And he writes me a note and says, your last tape was reviewed for fidelity and you received a 0. So basically you did absolutely nothing that you should have done in the treatment session. And me being me, I go all confrontational on him. I walk to his office, like, put that tape in there. Let me see that thing. And what appeared to be happening in that session, it was a maintenance session, so it was after the core exposures were done, is it looked like two guys having a conversation about football. And what it actually was me tailoring the intervention to the person in front of me who loved football. He wasn't. He would say to me, Doc, I'm not much into this academic stuff. Working class guy who didn't feel like the kind of vocabulary that you sometimes see in behavior therapy. He was turned off by it. So I knew that. So we came up with an entire suggestion about how to handle new symptoms that were emerging by saying, okay, you're customarily, this defense you're playing against likes to blitz up the middle, but you've been blocking that up just fine. What do you suppose they're going to do? Are they going to give up? Or are they going to come up with something new? And the guy played high school football. He's like, no, they're going to come with a corner blitz. Okay. What are you going to do then? Are you going to continue to overload in the middle, or are you going to have to swing somebody out? So we had this conversation for half an hour. And while Michael's watching the tape, and Michael wasn't much of a football guy, I was basically saying, here's what I'm saying and why I'm saying it. And at the end of that discussion, it was a 45-minute tape, so it was not a short one. At the end of the discussion, he takes the piece of paper that gave me a 0 and he puts it into the shredder and he says, well, all I can tell you is that's the way this is supposed to be done. You've got to tailor this to the person in front of you or you risk losing the person in front of you. And so there's always this balance. And I think that balance is really important. And I think it's even more important with ASD because you've got folks already telling you that that metaphor, that's not my metaphor. I don't get it. What are you talking about? I start sometimes on my sports metaphors with some of these kids, and the kid's like, but I don't like sports. Okay, so I had a nice sports metaphor ready for you. I better be ready to abandon that quickly and come up with some other way to say this to you. And the best way for me to do that is for me to ask you, I did this morning, what is it that you like to do? What is it that you're good at? And then the kid tells me what he's good at, and it was not sports, so my sports metaphor had to go away, and I needed to find some way to talk about music and learning how to play music and how that relates now to the concepts you're trying to teach. You got to be flexible. Kendall put it beautifully, I think, years ago, which and you see this popping out in the last 10 years as titled in multiple papers, which is flexibility within fidelity. So there's some core things I'm trying to get done, whether it's safety planning, whether it's ERP, whatever the case may be. How you do that has got to be a nuanced dance between you and the person in front of you, or else it is going to come across like a cookbook and you're going to not be cooking as well as you could.
Okay, great. Let's try another question. How do you work with clients with ASD with the lack of motivation?
That's a really good question, something that we end up talking a lot about. I think that the common wisdom is that when you're working with clients with ASD, that they are the least motivated members of the family. It's like if you're working with kids or adolescents particularly. And what I'll point out is that's not always been my experience. I mean, there are people I will run into who are not motivated, but I see that just as often among people who are not on the spectrum as on the spectrum. I think many times the reason that folks on the spectrum will come across as unmotivated is because it's quite possible, and we come back to what Marty was just talking about, which is what motivates them may be completely different than what motivates their peers, or what you think motivates them. So if we don't take a moment to figure that out, we can find ourselves really struggling. And a really good example of this is that if I were to ask you to write down, my background's in school psychology. So if I were to ask you to write down the top 50 things you think should be in your classroom motivation kit to get kids to do things you want them to do, it's amazing to me how many people will pick things that are socially mediated. So what do I mean by that? If you're really good, you get to be the superstar. I'm going to put your name under the green list at the front of the class. You get to be the line leader. Maybe you get to sit in the prime spot for lunch where everyone gets to talk about you. Whatever it may be, maybe I'm going to give you attention. And that is kind of like the go-to motivator that many of us will use, and not just for kids, although I'm picking on the classroom here. Okay. What's interesting is when we're talking about individuals on the spectrum, oftentimes, simply by the diagnostic criteria, you're talking about folks who don't pick up on social cues, who don't have a tremendous amount of use or at least facility for kind of communicating with other people in the manner in which we're accustomed to. So many of the things that we would typically use to motivate individuals are going to be a big swing and a miss. Not even really because the person may not like them, but they may not make that connection in terms of what you're talking about. So it really kind of behooves you to get to know the person, not only to ask what they like, but talk to their parents, talk to their friends, talk to their loved ones. If you're dealing with an adult who's married, talk to their spouse or their partner or their kids, whatever it may be, find what they like to do. It may very well be that the person you're talking about simply wants to be left alone. As a middle-aged guy who's been in a pandemic for a year, I can get behind the whole idea of being left alone is okay sometimes. So when we kind of think about using that as a reward or a reinforcer, that's not usually something we would think of, but it can be a very effective one. So, I mean, to me, it's very rare that I run into people who can't be motivated, but it's very common that I run into people who have not adequately been motivated in the past because the things we choose to use don't fit them.
Okay, next question. This person said, in my setting, I only see the child for 45 minutes. So would it be more appropriate to ask specifically about morning, afternoon, evening?
I'm trying to unpack that question just a little bit. Oh, okay, I think I understand. So in terms of kind of like how, whether asking how you've been doing since the last time I talked to you, but also kind of what are your routines throughout the day. If that's the question, is in terms of how do we unpack the whole day as opposed to portions of the day, what I would say is kind of divide and conquer. So maybe you start with what the morning routines are. And then kind of once you're rolling with that and you kind of have those things under control in a different session entirely, maybe we move on to the afternoon routines and we talk about what we've learned or what we found effective from the morning and what they learned of that process to kind of inform how we approach the afternoon, and then do the same thing with the evening routine. Very possible that question was asking something entirely different, but that's how I read it.
Okay. Let's see. Do you have any tips or advice on working with those diagnosed with ASD that have developed health and social anxiety regarding COVID?
Oh,
Yeah.
There's a lot. That's a whole other webinar. In fact, I think we did that one. There's a lot there, and what I would say that's particularly challenging, and I know Marty will probably have more to add to this too, because he has this great saying, and I'm going to let him say it, not me. But one of the things that's particularly challenging when you're dealing with individuals on the spectrum is another big kind of diagnostic landmark is something we call rule-governed behavior. And when we talk about that, I think a lot of us like to think we're rule governed, but here we're kind of talking about a generalization error. So if I have a rule that works in one setting, I'm going to use that rule all the time, everywhere, every setting, with every person, all the time, because that if it works here, it will always work. And so what we'll see is that maybe if I'm out and about and I decide to have a day out on the town, and every time I get done interacting with people, it makes sense because I've been touching them or touching their things, that I need to wash my hands really well, or I need to use hand sanitizer. And when we kind of start thinking about this, then what we'll see is we begin to start generalizing that behavior inappropriately back to our house, or places where I'm not around other people, or maybe even if I talk to someone via Teams, well, I just interacted with them and the rule is I have to wash my hands, so I'm going to wash my hands now and use hand sanitizer. And so we'll start to see things like that show up. So my typical way of addressing that is to kind of point out times when that rule is appropriate and when it is not, and kind of give them examples of situations and basically ask them, what do you think about this? Yes or no, why or why not? Are there other examples of rules or guidelines that we use that change over time? And kind of what we want to get at is not so much undermining the rigidity, but kind of building in some flexibility to the rigidity that we see. Marty, did you have more to add to that?
Yeah, I mean, I think the phrase you're alluding to is something we did a full-on managing contamination fear in the context of COVID, and I think off the cuff, when this one stuck around for a bit, which is a phrasing I use, and I think it could be helpful here, which is you follow the CDC, not the OCD. So what would Dr. Fauci say? And I had a kid once who was explaining to me that he was concerned about COVID. And as a result of that, he was doing what the doctors were saying, which is he was washing his hands more frequently. And I said, well, what would you guess your frequency is right now? And breaking it down over the course of an afternoon and an evening, turned out the frequency of hand washing was 65 times. And he was 65 to 70. And he was not leaving the house 64 to 69 times. So to me, a rule-governed behavior, Dr. Fauci said, wash your hands, but he didn't necessarily say wash your hands when you're sitting in your own living room, which is not the same thing as sitting on the floor at Target's bathroom. And so what I'm trying to do in that circumstance is really to help them understand, and it always starts with what do they already know? When I'm dealing with kids, especially kids with ASD, I want to know, what have you been told? What do you know about this illness? What do you know about how to contract it? Because sometimes psychoed can be incredibly valuable. And if they say that, you can get it, you can be standing 20 feet away from somebody, and if they have COVID, you're going to get it. And I start to drag, I start with this sometimes, so I'm a little cautious with the ASD crowd on this one, which is, I talk about the Red Death. So 13th century Europe, where 1 out of 3 people were dying of the Black Plague. And I say, first of all, let me explain. I think caution's important, but this is not the Black Death. So let's just do the math. And some kids really love the math. And I can start to explain to them that the likelihoods that you're, just because it could happen doesn't mean it will. We take reasonable precautions in a reasonable way to protect ourselves and other people. But when you go above and beyond what's being asked by Dr. Fauci, et cetera, is you might actually be not reducing the likelihood of getting infected or getting someone else infected. But what you might be doing is you might actually be messing up your own life and letting the world get too small. So we got to balance those two things. So I want to know what they know. And sometimes what they know can be easily corrected. And sometimes what they know is they'll tell you, well, it is, if it's possible, therefore it's probable. And maybe that's where I get my nuance in there too. But the long and the short of it is I'm going to start with what they already know. If they like they've memorized the CDC website and they're still taking this approach because better safe than sorry, I want to go after the better safe than sorry idea. But I'm always going to start with what do they know? How do they understand this? How do you think this works? Because sometimes there's some misinformation in there for folks with ASD. There's some misinformation in there for other folks too. And I want to correct that as best I can. I think we might have hit the time.
Yeah, we hit the time. So that's all the time we have for questions. Thank you. And if we didn't get to your question, please feel free to send an email to webinars@rogersbh.org, and we'll try to get to those. Many thanks to our presenters for taking time away from your clinical practice to share your valuable insights with us today. Helping a patient on the road to recovery means collaboration among everyone involved in their treatment. With locations across the country, our treatment teams are ready to partner with you. Rogers Outreach representatives are happy to answer questions regarding our treatment services, as well as learning more about your practice. So before we conclude, I'd like to ask our presenters to share a few additional resources on this topic with our participants. Okay, so that about wraps it up, everyone. I want to remind our participants that those of you who meet the required time committed will be eligible for CE credits. So about 30 minutes after this webinar ends, you'll receive an email with a link to your personal dashboard on ce-go.com, where you'll be able to access PDFs of the PowerPoint presentation slides handout and a complete list of references. So those of you who have met the time requirement to qualify for CE credits will need to complete the evaluation to download your CE certificate for the event. If you have any questions about this follow-up email, please contact support again at ce-go.com. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Have a great weekend, everyone. Thank you.